I think first and foremost this workshop has been quite remarkable. It's been an absolute pleasure to be here. It's been an incredible blend of science and clinical medicine, and then also having patients come and Q&A session with our patients has been really something. So I want to really applaud Dr. Kartik Ramaswamy and all the organisers for a really outstanding workshop. In that spirit, the remit that I had was to talk about upfront therapy in myeloma, how that has really evolved and changed dramatically in the last decade, and at the same time bring in as many of the concepts from the meeting that we've had. Part of the meeting has been focused on immune therapy and the complex biology of myeloma and patterns of relapse and complexities of pathogenesis around inflammation and so forth. So lots of things to weave into the upfront space. So in the context of this talk, I really wanted to frame the pathobiology of myeloma, that one size really doesn't fit all. It's an incredibly complex disease. There's tremendous heterogeneity between patients, and above all, in a patient over time, the disease changes very dramatically. So we focused on the genetic instability of myeloma and what that looks like. And with that mutational instability, it actually becomes very important to be strategic in how you choose your treatments. And as you also think about mutational instability in the disease, and with the many thousands of mutations that exist in any one particular patient's disease at diagnosis, our treatment strategies have to be tailored to ensure not only do we throw a big net around the myeloma itself, but also what we do immediately has maximal benefit in the longer term. And I think this is a very important strategic construct to get. So my talk was really to focus on the success of the quadruplets, how they have really revolutionized the frontline treatment landscape, but also our recognition that in that context, there's an evolving role for transplant. And really what that focuses on is that whilst transplant is clearly a standard of care in most healthcare jurisdictions today, that position is probably changing over time. And we're recognizing it has a role, but certainly we're going to be thinking of it differently, I think, in a decade from now, and maybe even as soon as 5 years from now. Doesn't mean it's going away, but it means that it may actually have a more limited role in selected patients, or in fact, it may continue to have an important role in high-risk disease. We'll have to see. But the most important thing I wanted to share with the group today was quads have done an amazing job. We've now got a PI IMiD steroid backbone to which we add a CD38 antibody. Daratumumab has led the charge in this regard with the success of the Griffin trial and then Perseus with transplant. Now, of course, we have amazing data from Cepheus, where RVD has been combined with Dara in the non-transplant population, and the results are amazing. But also what I focused on was the success of isatuximab. That isatuximab as a CD38 monoclonal antibody is, I think, subtly but importantly different. It binds to a different epitope in the CD38 complex. It has different patterns of killing in the way that it kills in the laboratory and what it does to the immune milieu. And by doing that, I think there may be some subtle differences, and particularly in high-risk disease, and in particular in 1Q amplified disease, isatuximab does seem to consistently show that it's a very powerful antibody, and it works exceptionally well in combination with either RVD or KRD. Now, obviously, daratumumab is doing exactly the same thing, and Cepheus is really performed exceptionally well. But I think we all think that the high-risk disease that isatuximab has been specifically deployed against in the setting of both KRD and RVD has really performed very well in that setting and meeting that challenge. So we've looked at the triplet combined with the antibodies to generate the powerful quadruplet. And what I framed there, we're looking at progression-free survivals from, say, the IMROS study that are estimated between 80 and 90 months in a non-transplant eligible patient. So this is really exciting and great news for patients. So that was a main frame of the talk. And then the next part of the talk was really addressing frailty and how we need to address the frailer, more vulnerable patient who may not be able to tolerate all 4 drugs, or if they can, there'll need to be major adjustments made to dose and schedule to allow optimal tolerability and to understand frailty and what that means. So we spent some time on that. We spent a lot of time on maintenance and how much that matters. And then we further discussed the evolving role of transplant, and really just to get the idea that if you have a standard risk patient who is MRD negative and appears to be so in a sustained fashion, then it is, in my opinion, reasonable to keep transplant in reserve and reserve it for those patients in whom their disease pathobiologically may warrant a more aggressive approach. And I think it's no more exciting a spot than to bring in the new exciting treatments. CAR T, bispecifics. These treatments can arguably really come now to the upfront setting, and we firmly believe that these new immune therapies will really transform the upfront treatment paradigm. And then part of the discussion today was to look at, when we talk about one size doesn't fit all, what does that mean? In high-risk, transplant, for example, clearly has made a difference in the triplet era. In the quadruplet era, it remains to be exactly seen whether you need transplant in the way that we did, for example, in determination, where clearly in high-risk patients, high-dose melphalan with stem cell support made a difference. Standard risk, much less so. I think the next question then is not only high risk, but what other patient subgroups matter? Well, one of the things in determination that we were so happy to have had was a 20% or approximately 20% participation of African Americans. And with that, and with the equality of access to care, with free medicine and no, therefore, disparities that existed in treatment access, we were able to take a very hard look at how African American patients did in our study. And what was particularly striking to us is that whilst they did well with RVD transplant, they really did well with RVD and transplant kept in reserve. That was quite remarkable and counter to the data that we saw for the remainder of the patients in terms of PFS, recognizing that in overall survival there is no difference, despite the fact that only 28% of patients have had the delayed transplant so far. So that in itself is very important. But the fact that we saw African American patients doing so well with just RVD alone was quite noteworthy, and we tried to better understand why. And our working hypothesis is that body mass index may be relevant and other factors, but above all, there's this entity called Duffy null. And Duffy null is a red cell phenotype that has been selected for over the millennia because it protects anyone who has it from the consequences of falciparum malaria. So in African American patients and in anybody of West African heritage, it's expressed in about 60 to 70% of people. This means that they are very much protected, obviously, against the consequences of malaria. But what does this mean in the modern era? Well, in the modern era, if your red cell is hardened to resist the falciparum parasite, unfortunately, the downside of that is it's less effective at dealing with cytokine stress and chemokine stress, such that the role that the red cell has in terms of being a chemokine and cytokine sink is gone. That being the case, the ability of that individual to handle anything that's a pro-inflammatory or intensive stress to their system may be, in fact, impaired. So we thought, as a working hypothesis, could it be that Duffy null has something to do with this? So we looked at white count, we looked at all the factors that we normally associate with Duffy null, because it's so-called African leukopenia, that if you have Duffy null, that you're going to more likely have a low white count. And we found actually that had nothing to do with what we were seeing. Something else was going on. And we actually looked at our Duffy null patients to see how they did with early transplant or delayed. And remarkably, those patients who did not get an early transplant or delayed transplant enjoyed remarkable PFS benefit, much more than we saw for the remainder of the study. And this was in favor of RVD without early transplant. So with that observation, recognizing that it's a subset, and therefore it's hypothesis generating, so it's not confirmatory, far from it, it's just a really important hypothesis, we have a working idea that in some patients a less intensive, less pro-inflammatory approach may result in better outcome. And with that in mind, my colleague Dr. Lauren Merz is going to be presenting more data on this at the upcoming CTN meeting and ASBMT in Hawaii next month. And we're taking a much deeper dive on this to better understand it. But it exemplifies why randomized trials with participation of patient groups who are not necessarily well represented in other trials becomes so important, because out of this work has emerged an idea around Duffy null that obviously we have to further investigate, further understand. But if it's true that actually if you're Duffy null, a less inflammatory, less aggressive approach to treatment may actually bear fruit, that obviously for those patients is tremendously important to understand. And finally, it might give us a clue as to why in patients of African descent there is more myeloma. Because at least in part, if 70% of African American patients are Duffy null and they handle inflammation less well, we know inflammation drives the pathogenesis of myeloma. So is there a relationship there? So all sorts of exciting stuff, but that was a part of the conversation today, and actually from the audience generated tremendous interest. So a very exciting session, and I thought, hopefully a very useful contribution to the workshop.